welcome everybody. I'm going to hand over to Simon DeLucian, who is going to chair the meeting and introduce the meeting as we go through the various aspects and subjects of what we're going to be going through today.
Good afternoon, everyone, and thank you for giving up your time on a busy clinical day to listen to this presentation. I'm presenting about the Oxford Royal College Research and Surveillance Centre, which is one of Europe's oldest sentinel systems. We're now, by the time we get to April next year, we will have been completed 55 years of sentinel surveillance, which is a pretty unique achievement. And what's really underpinned this, as is on the slide currently, is sampling. We're a network that has great data quality, but we also take samples. If I whiz on a slide, please, Carol. I'm giving a brief introduction. We're going to talk about how the data we provide are used by our public health colleagues. So for years, Public Health England, but now UK's Health Security Agency. Practice tips from a practice manager in the network, possibly the best bit of the show, engagement in research, and a summary. If we whiz on a slide, and those speaking are Conal Watson, who leads on influenza and influenza vaccine effectiveness for UKHSA, Sarah Davis, and Nick Thomas. If we just move on a slide. Just to give a very brief overview, as I've already said, we're one of Europe's oldest sentinel systems in our 55th season of producing a report every week, and that'll carry on over Christmas and New Year. And you can look at our weekly report online if you want to know what's happening with flu or happening with COVID. We've recruited practices to be nationally representative, and you can see the dots across England and Wales. And practices share data with us for SQUARE purposes. We share data for surveillance, quality improvement, research and education. And we like to think of ourselves as a network as well as a database. And we're really very grateful for everyone's support, and like to promote the message that high quality records support high quality care, or my coding is caring sentiment. If I can move on a slide, please, Carl. Just to say the key bits of sampling we do in the network, and if you're a practice online and you'd like to get more involved, please be in touch with the team. But we do swabbing, virology sampling, and real interest this winter about co-infection. We see RSV and COVID, RSV and flu, any of the other combinations. So if you're interested in doing more virology samples, then please speak to us. We also, when people attend for a blood test, a number of our practices take an extra blood bottle and say, do you mind if we take an extra blood bottle? Verbal consent is all that is needed to be used for serological surveillance, looking for antibodies against circulating infections. There's some links on here which I will leave, which is to which I won't talk to, but we have a full set of documentation about this process if anyone is interested. I'm sure the slides and links will be made available afterwards. So if you can move on one. And what I'd like to do is hand over to Conal Watson, who is going to talk to us about the surveillance we're involved in.
Thank you, Simon. I'm going to stop sharing my screen so that Conal can put up his presentation.
Great, thanks very much. Delighted to join you all. Super. So, I mean, I really just wanted to outline and give a flavour of how we use these, and there'll be more in future seminars, I'm sure. And I wanted to head back a bit to those kind of pre-COVID days that we all remember, when we used to look at flu as the #1 pathogen, and I'm always mindful when Simon tells us just how long the scheme's been running, that when I show the this slide, which is our GP influenza-like illness rates, and we use the fallout of the 2009 pandemic, the 2010-11 season, as our measure of what a really bad flu season looks like. And actually then think back that the RCGP scheme's been running since before the H3N2 pandemic in 1968-69, and just what utility there's been of the schemes through that. So yeah, current activity of flu, and obviously, as folk are well aware, the COVID control measures have been putting downward pressure on flu. And so one of the notable things of the scheme is how it adapts to the circumstance. So these are our indicator lines that we use in the weekly UK HSA surveillance report, looking at influenza-like illness, the black line, lower respiratory tract infections, the green line, and this new indicator of COVID-like illness, which, whilst obviously the dominant thing, there is signal in the influenza-like illness line. It's not that it's dropped off entirely. It's still part of our surveillance set. But as Simon said, one of the unique contributions of the Royal College GP surveillance scheme is sample collection. And here we're getting the indicators, as you can see, if you're following closely, little green dots of H3N2 being detected. And so these are some of the potential early signals of flu activity this winter after a long period of the absence of flu. And I was just going to pull out a little bit of the respiratory syncytial virus surveillance, because we've been having such an unusual, I was going to say season, but we've only just arrived in RSV season, but things have been up since May, June, and this has been coming through in the RCGP community surveillance. So a vitally important bit of triangulation that we do alongside the more laboratory-based or the more hospital-based surveillances to know what's going on in the community, what's going on in primary care, and the RSV case count, the RSV positivity gives us that. So we take these data are part of the surveillance data that we take to the specialised commission groups who are looking at palivizumab for the very high-risk children as part of our considerations for how long this out-of-season programme continues. And and so just to emphasise how vitally important that is. And then I was just going to wrap up with a single slide on the big set piece for what we use the Royal College GP surveillance data for. And this is work done by my predecessor Richard and colleagues across the UK. So RCGP and colleagues in RCGP in England and colleagues across the nations. And this was some of the first evidence of the different effectiveness, the better effectiveness of using adjuvanted influenza vaccines in older adults. So one of the real strengths of UK surveillance is having these strong links into primary care, and very grateful to all the colleagues who contribute from their practices. Thanks very much.
Thanks, Connell. Simon, do you want to add something while I turn back on my screen from anything that Connell's shared with us? It was very interesting.
Yeah, I mean, I think one of the remarkably interesting things, I've got a set of slides that go back to the 1960s, which show consistently how RSV has come every year up to this one in the last weeks of the year. The under 5 peak in acute bronchitis in primary care, perfectly matching with the RSV spike. And then this year, completely out of a season, and interesting about, and why work is so important in this reset year, and we'll either do a transition back to the old pattern or maybe not. And that's why I keep coming on those samples as they help us answer that question.
Thanks, Simon. basically now I'm going to share some practical tips with the members of the webinar. And I'm going to invite Sarah to put on her screen. And Sarah, perhaps you and I can ask you a few questions, and we can give some very practical tips, because you're a very successful practice as far as sampling goes. So one of Simon's favourite people, shall we say. So welcome, Sarah. You're a practice manager of how many years?
8 years.
Yeah, so well versed in what goes on in general practice. So can I ask you, first of all, how do you make sampling work in at your practice? So what approach does the practice use?
Okay, so we make sure we have regular ordering and delivery of the sample boxes. But when they come, often there's so many deliveries within general practice, lots of things sit in a box. So unless you kind of interact with it and have a sorting process, it will sit in a box for a number of weeks. So I make sure either myself or the reception manager intercepts the sample boxes and we sort them. So I've got one here for just the sampling for reception, and we'll go through and we'll put all of the correct forms and the envelopes, so it's a lot easier to use. And the same with the serology boxes, we'll take out the blood bottle and we'll set it all up on the blood table for the HCAs to use. So they've got a little tray and they know they can just grab one and then put it together after the patient's left. So we also have regular engagement sessions with all of the staff. So for example, in the clinical meetings, we will talk about the process to gain our SV sampling with under 5s. We'll also have regular buzz meetings every day and say, okay, we're going to do a real push today. I can see that some of the patients come through with their parents and we haven't done any sampling. Why haven't we done it? And why it's good to be doing the sampling. And the same with flus. So if it's not COVID, we can still test for flus if it's flu-like symptoms. So get a test kit out to them. Recently, we also changed the process after people had COVID positive samples come through. We also now ask them if we can send a code to them and they get a Oxford sample sent out to them, and they do that on top. So that's working really, really well, and we've seen an uptake in that. With our HCAs, we have everything set out for them, and they've been encouraged to do the sampling by having extra time given on each time slot for patients. So they've been allowed a double appointment where it could be 5 minutes for phlebotomy appointment, it's now 10 minutes. So they have the luxury of being able to talk to the patient, consent them, and have a little bit more time for their appointments. And that's really pushed things forward. So if they decide suddenly, do you know what, I don't want to do it anymore, it's okay, well, we can revert back to normal phlebotomy practices, or we encourage doing the sampling because of what it gives us. And often that's a little push to encourage the HCAs to go forward with it. In the nurses' rooms, if they do impromptu testing and blood tests for doctors when it's an emergency and the HCAs are full, they've also got sampling kits to hand as well. So they've got a box put in their room. And I think it's just making sure it's all organised for them and just how's it going, what are the patients saying, giving a really positive spin to the patients as well about the added value that they're being able to give to the research, and it works really well. We hardly have anybody decline. But there's also a leaflet you can give to them about the information. So if they do want further information, then you can give that to them.
And how do the forms work, Sarah? I mean, you know, that's one of the things that I find we get sort of, we can't cope with filling in the forms. How do you manage that in your practice?
So the HCA just uses her label machine. So she's printing off labels anyway to put on the blood bottles. She just prints an extra one off, pops it on the serology blood bottle, and she puts one on the form. I have somebody that pre-stamps all the forms with our practice details. So that's already done for her. So it's literally a little label and that's it, and time and date it. And it just gets pop together. But like I said, we've extended the appointments and she has more coffee breaks as well, just to compensate.
that must go down well.
Yeah.
So in terms of you know, patients not getting their results back, we find that some practices find that doesn't go down too well. How do you cope with when they ask about blood results coming back for the serology samples?
Okay, well, we obviously they're here for the purpose of having phlebotomy for another purpose anyway. So we're not calling people in unless it's on a different COVID research. So we're just saying, to be honest, with the current situation, Oxford is able to use this sampling to develop different practices with COVID, understand prevalences, understand what's going on at the moment with flus and everything else. The information is vital to being able to push forward. And by that point, they just say, yes, that's fine.
Well, and I think Connell showed that well today, because you've got even more evidence, you know, to back up what you say to patients, because you can actually see the way it's being used.
Yeah, I think just getting their buy-in and them feeling like they've made a difference is enough. And a majority of patients are definitely 100%. Even those that are really scared of having blood, they're like, okay, I'll go for another vial.
And the opportunistic way you do this, I mean, you say you don't actually have to do any searching, you just do it all opportunistically, as you see. Any other hints and tips on that opportunistic point?
We do have a box in reception by our dispensary, and we have a little notice saying take a test kit for you know, for when you need it. If you've got flu-like symptoms and COVID symptoms, then please take this for research as well. Even if you want to go for a drive-through, take your research test kit just to help the current situation. And they've been going through those as well.
And I know that you mentioned just briefly there when you were talking about your stand-up buzz meetings, I think you call them. So how do you keep the team on it, so to speak?
Well, they quite like being able to add a difference as well, because, for example, children, they like to know that, especially if the children are quite unwell, what it is, and they do get the results back for that. And obviously then they have follow-ups. So I think that's quite an easy one, but just trying to keep saying to the staff, any children under 5, let's consent the parents, get the test kit. The test kit can go out because we're a dispensary as well with the medication. So you just wrap it up with the medications and the parents do it and just pop it in the post. So it's quite an easy process.
Great. And you had an example you said you used for a bit of publicity. That was for a sample result you recently got. Yeah.
So we had a positive sample for flu, and you kind of forget about the flu because you're searching for all these COVID patients and the positives and dealing with all of them. And it was like, oh, we've got our first influenza A. So we were asked, went back to the patients and asked to be consented to publicise on our social media that there's now flu in the local area, and to be mindful about it not just being COVID, about being flu, testing for your flu, and getting the information as well. So
and so you did that anonymously, but it gave a boost to your people coming across. Yeah, that's absolutely great. And then when you get the results in, I know this is not something that you actually get involved with yourself, but you use eLabs. So I know you've got Amy, who is your research lead, who handles a lot of that. How's that work?
Absolutely fine. So she looks for anybody. We have processes for positives for COVID and flu, because flu can be extremely nasty. So and they contact the patients for any positives. Obviously, if they've already been notified, we just send a text saying if you need support or help, this is the process. But if we find the positives, we'll phone them and engage with them and tell them about what's available for them in services. Because we've got COVID hubs, and we've also just got our own porta cabin to see patients that are a little bit more infectious, including flu, to see them just outside the practice so we don't bring it into the practice. So we've got lots of initiatives running.
So that's great. And I mean, that way, the research lead is pulling out the results, printing them for the coders to put in. So you actually got a full loop going there on the actual putting it into
we
the
code
system.
everything. So we even code the serology as well. So as soon as the blood sample is taken, it just allows us to pull a search and also submit those to you guys as well.
And I know that you're very keen on research in your practice, and that's shown by what we see here. So thanks for that, because I'm going to hand over now, but thanks, Sarah. There's some really great practical tips there. I'm going to hand over to Nick Thomas, who is going to chat through how the RCGP can actually help with research. Thanks, Nick.
Thanks, Carol. So yeah, as Carol says, I'm Nick Thomas. I'm the clinical lead for research at the RCGP, and I'm a jobbing GP in West Oxfordshire. I'm very keen on research, which is great. So it's part of my major role, really. What a brilliant session, and thank you so much to hear Sarah there, because that's actually brilliant. It really shows how important this work is, and just that one little swab that's done many, many times creates all of the information that Simon and Conal have already told us about. So absolutely superb overview of what that one little sample can how it can help and what it adds to in that bigger picture. So every practice taking part in this is really playing a vital role right through, and on the whole members of the team as well. It really came across of how practice engagement is so important with all members of the practice. So that was superb. Thank you so much for that. So yeah, on behalf of the RCGP, research is so important in our relationship with the RSC, which, as Simon's told us all about already, is how important that organisation is, and how good the surveillance work with Public Health England has gone on for so many years. It's really interesting and fascinating. The other thing the RCGP can do is it really supports general research within practice as well, which is really important to think of. How do we do research? How do I do that? How do I take that first step? And using Research Ready, which is a self-accreditation tool, that's a program really helps everybody to really practice to sort of engage and really take that first step in understanding how we can do that. Okay, so if I do a bit of research, I can do a bit of a mail out, and I can do some surveillance work. That'd be great. That'll start you off, and then practices get the feel of it. They quite enjoy it. And so then they move on and they do more research trials, as Sarah has alluded to already, which is absolutely fantastic. So just to talk about that, really, Research Ready is a really good program. So as an introductory path for new practices who want to take that first step, do the surveillance, to take really those big first steps in going, okay, I understand what's going on now, get the feel out there. We can support all of that work within the college and really hold your hand in the early steps. And so I just wanted to, that's really what I wanted to say today, if that's all right. And I'll pass you back to Carol, but any questions, probably please contact me. I'll put my email in the chat, and thank you very much for your time.
Thanks, Nick. So we're going to finish off with Simon. I'm going to just share my screen and get up the last few slides from that. So let's just get that going. Can you see the slides, Simon? You're on mute, Simon. Thank you.
There we are. Try again. I think I'm there. Yeah.
Yes,
Right.
thank you.
Excellent. So if I could just very quickly, in summary, run through just how important every sample that is taken, and you can see the summary that of our team's thoughts about what's needed. Get kits ready in rooms, reminders. We all need reminders in primary care. Swabbing kits available and to hand. I'm not sure with us about with prescriptions anymore, as I think it's a long time since I did a paper prescription. But how we contribute as GPs and general practices to this coding system is really important, and our practice liaison team are here to help. If I can just whiz on to the next slide, we try to contribute through the data we pass to our public health colleagues, but also through reports. The weekly report, as I say, is in its 54th year. It includes, if you see the graph halfway down, what's happening in COVID, and we also have an interactive observatory. We provide practices matching dashboards. So if you want to see how your flu is going, compare with your peers, or pneumococcus vaccination, these are all things that are included in our dashboards. We include remuneration per sample taken or for involvement in projects. And we have a practice liaison team that Carol leads who are here to help. If I just whiz on, and I will leave this just in the pack, sorry, on 5.2, you've gone past 2. There is slide 5.2, it's got all the governance links to our data sharing agreement, to the how we go about pseudonymizing data to protect privacy, etc. The legal basis for what we do is Regulation 3, which is the same legal basis that's been extended into the COPI notices that have been used during the pandemic. If I can just move on to the final slide. We really do get fantastic support from colleagues in sharing data to our patients who provide specimens, and very few of our patients, just under 2% of patients at surveillance centre practice opt out of data sharing, and a whole range of colleagues. And we're always welcoming new members. We've got exciting things happening, including gastroenteritis surveillance and sampling, again being done with UK HSA colleagues in Colindale. And as one little pitch things, I think we also can set a good example by being among the first of our colleagues to get vaccinated. The last slide has some connections on, which again be distributed, and we're delighted to see our reports and data as widely used as possible, ultimately to improve the health of the public and the practices we will serve. Thank you very much for attending, and thanks to all who've contributed to make this seminar a success today.